So my name is Dr. Miranda Harris and I'm a Public Health Registrar at ACT Health. I'd first like to thank Capital Health Network for facilitating the webinar today, and also thank you all for joining us very early in the morning for this webinar online. All right, so as background, coronaviruses are a group of viruses that can affect humans and animals. The COVID-19 outbreak started in Wuhan in China in December and has since spread to other countries around the world, including Australia. There is a wide spectrum of illness from mild to severe, and the majority are mild. And the WHO declared COVID-19 a pandemic on the 11th of March 2020. As of the 24th of March, so yesterday, worldwide there have been over 334 cases, over 2,000 in Australia and 39 in the ACT, and no community transmission identified in the ACT. So COVID-19 is spread by contact with respiratory secretions and fomites. Airborne spread has not been reported, however, it can occur during certain aerosol generating procedures in healthcare settings. The at-risk groups for COVID-19 are people who are older than 65 years and also those people with a chronic or other medical condition. And elderly residents may experience worsening of their underlying health conditions, such as congestive heart failure and asthma, when infected with COVID-19, and complications of the infection can include pneumonia, respiratory failure and septic shock. So in preparing for a potential COVID-19 outbreak in an aged care facility, it's important to develop an outbreak management plan, and existing plans can be adapted for this. It's also important to have protocols for enhanced infection control measures. These should be available and staff should be familiar with these. A workforce management plan should be able to cover 20 to 30% absentee rate, and staff education and training is recommended, particularly a refresher training in the appropriate use of PPE and also specimen collection. And it's also important to maintain adequate supplies of PPE and hand sanitizer. We'll first talk about staff working in aged care facilities in the context of COVID-19. It's really important for staff to be monitoring for fever or acute respiratory illness. It's important that they do not come to work if they're unwell, and if they're at work, they immediately exclude themselves, go home and let their manager know. It's also important that they get tested. So in the ACT, staff working in aged care facilities with an acute respiratory illness or unexplained fever meet the criteria for COVID-19 testing. And they should go arrange testing through their GP by phoning ahead before arriving at their GP. And if they can't get into their GP for testing, they can attend a respiratory assessment clinic. And these are the Western Walk-in Centre and also the drive-through at Epic. If a staff member tests positive for COVID-19, they will need to remain in isolation until CDC has provided advice that they can come out of isolation. If the test results are negative, staff members will need to be excluded for 5 days from the onset of their illness, as would happen with influenza. For staff, it's also really important to avoid working across other facilities or in hospital to prevent any spread of the virus. And staff and visitors who have recently returned from overseas or who are a close contact of a confirmed case will need to self-quarantine at home for 14 days and cannot attend work. So in terms of the clinical presentation of COVID-19, the most common symptoms are fever and a dry cough. However, it's important to note that fever may be absent in the elderly, and in a resident who has an underlying cough, usually it would be important to monitor for a new or a worsening cough. Less common symptoms include, other symptoms include shortness of breath, sputum production, fatigue. Other symptoms include sore throat, headache, myalgia, arthralgia, and nasal congestion. And it's also really important to be aware that similar to flu, in the elderly, COVID-19 can present differently with increasing confusion, worsening chronic conditions, and also loss of appetite. And it's important, therefore, to consider testing in any resident with new respiratory symptoms. So for residents, it's important to have systems in place to monitor residents for fever or acute respiratory symptoms. It's important to have a high index of suspicion in elderly residents with new respiratory symptoms, and any residents with acute respiratory illness, so cough, shortness of breath, or sore throat or unexplained fever, for example, not related to a urinary tract infection, they should be isolated in a single room. Medical review should be arranged if indicated, and prompt testing for COVID-19, influenza and other respiratory viruses should be undertaken. And please contact CDC for advice around this if needed. This approach is precautionary and it really facilitates early recognition and management of cases. So in terms of testing, a resident's GP should authorise testing and specimens should be sent to ACT pathology if possible. That's because of the quick turnaround time with ACT pathology and also because CDC can check the results here. In terms of the specimens to collect, we want you to collect just one flocked swab of the throat followed by the nasopharynx. So that that differs from when you would collect specimens for influenza in previous seasons, where we want one sample that is taken from the throat first, followed by the nasopharynx. And this is being done to preserve swabs and also testing materials. And if you also had a resident in which you suspected influenza, we would also be asking you to take one combined flock swab rather than two, as we have done in previous years. It's also important to collect the sample in the resident's room with the door closed. So when taking specimen collections, it's really important to wear the appropriate PPE. The appropriate PPE is contact and droplet precautions for residents with mild illness, and I'll explain what that means a little bit later. And it's contact and airborne precautions for residents with severe symptoms that are suggestive of pneumonia. So that would be fever and difficulty breathing, severe, frequent or productive cough. It's important to stand slightly to the side of the patient when you're collecting the specimen in case the collection elicits a cough or a sneeze. And residents don't need to be sent to hospital for the purpose of testing. It's important to ensure that all specimens are labelled accurately and completely to ensure that the testing is able to be processed. So this is what the ACT pathology request form looks like. I'm sure you're familiar with it. The stars identify the areas of the form that need to be filled in. It's really important that the top section up here matches what's on the specimen. It's also really important that in the address box, finding my cursor, in the address box it's clear that sample has come from a residential care facility, because this will allow for the COVID testing to be done and it will also prioritise the testing. If it's a verbal order from a GP, it's important that that's written down here in the doctor's signature and request section, and the GP name and provider number also needs to be provided and the form signed. So in terms of the outbreak definition for COVID-19, a potential outbreak is defined as 2 or more cases of acute respiratory illness in residents or staff in a residential care facility within 3 days, so 72 hours. And acute respiratory illness is cough, sore throat or shortness of breath, but it's also important to have a high index of suspicion in elderly residents for new respiratory symptoms. We're asking that when you have 2 or more cases of acute respiratory illness, that you contact us at CDC on this phone number, and we'll provide advice on infection control, outbreak management and testing advice. And this differs to ILI outbreaks, where we ask you to notify us once you have 3 or more cases. And again, this is a precautionary approach. When you phone us, we'll collect information about the residents and staff who are unwell, what their symptoms are, onset date, where they're located in the facility, whether there's been any urgent GP or hospital referrals. And so it's similar information to what we would ask when you phone us with information about an ILI outbreak. We ask you to keep a line list of all the residents and staff who have symptoms, and that this be updated daily and provided to us at CDC. It's also really important to have a single contact person or a small team that is responsible for reporting and liaising with us. A confirmed COVID-19 outbreak is defined as 2 or more cases of acute respiratory illness in residents or staff within that same time period, but where at least one of the cases has been confirmed to have COVID by laboratory testing. So in terms of PPE, Contact and droplet precautions are you're required to wear gloves, a long-sleeved impermeable disposable gown, surgical mask and eye protection, and this is required for all staff and visitors who are in contact with suspected or confirmed COVID-19 cases, and also when collecting upper respiratory tract specimens in residents with mild illness. Contact and airborne precautions are required when caring for severely ill patients with excessive coughing, for aerosol generating procedures, and these are unlikely to be performed in an aged care facility, but include things like non-invasive ventilation, cardiopulmonary resuscitation, and high flow nasal oxygen. And also for the collection of upper respiratory tract specimens in residents with severe symptoms suggestive of pneumonia. And the difference between contact and droplet precautions and airborne precautions is that instead of wearing a surgical mask, you'll need to wear a P2 or N95 mask. So it's important to note that nebulizers have been associated with a high risk of transmission of respiratory viruses, and their use should be avoided in any residents in whom you suspect may be infected with COVID-19, and a spacer or puffer should be used instead. It's important to perform hand hygiene before donning PPE, during and after doffing PPE. And it's also important to note that the incorrect removal of PPE is associated with the risk of personal contamination and spread of infection, which is why we recommend refresher training of appropriate use of PPE for staff. I'll just quickly run through cleaning during an outbreak. It's important that cleaning and disinfection is undertaken during a COVID-19 outbreak, using either a two-step clean with a detergent first, followed by a disinfectant, or a 2-in-1 step clean using a combined detergent disinfectant product. Cleaners should use contact and droplet precautions, and the cases room or zone should be cleaned daily, ensuring that frequently touched surfaces are cleaned more frequently. And these would be things such as bed rails, bedside tables, light switches, door handles, etc. And also all equipment, walking frames and sticks of the case need to be cleaned regularly. And any equipment used within the cases room should be disposable or dedicated to the case where possible. And there needs to be increased cleaning in communal areas throughout the facility during an outbreak. So now we'll just touch on social distancing and the key points related to that. So as of the 23rd of May, visitors to aged care facilities are restricted to reduce the risk of transmission to residents, and they're restricted to quite a small group of people. So they need to be an employer, they need to provide goods or services, provide health services, care or support to the resident, provide end-of-life support, emergency management or law enforcement. No school or childcare groups are allowed into aged care facilities, and visits need to be limited to 2 hours, with a maximum of 2 people at a time, once per day. And visits should be in residents' rooms, outdoors or a specific area, and not in communal areas. There should be no large group visits or gatherings, and social distancing should be maintained at 1.5 metres. Given these significant social distancing measures and the potential for the mental health of residents to be affected, it's really important to encourage family and friends to maintain contact with residents by phone or video calls and social media apps if that's possible and where that's appropriate. So as per the CDNA influenza guidelines for residential care facilities, facilities should aim for vaccination coverage of 95% or more in both residents and staff. And it's really important this year to try and achieve that, because we really want to avoid co-infection of COVID-19 and influenza in residents. In terms of vaccination for residents, they are eligible for NIP-funded vaccine, where there may be difficulty for a GP to come in to a facility and vaccinate their residents or patients directly. RNs can vaccinate with a prescription from a GP, and CDC, the Communicable Disease Control Unit, can deliver vaccine stock for residents, but we will need a couple of days' notice. And to do this, you can call the immunisation team on this number on the slide here. For staff and visitors, I'll note that from the 1st of May, they must have influenza vaccination to visit or work. Vaccines will be available on the private market through GPs and participating pharmacies, and we encourage, where possible, that vaccination clinics are provided on site for staff and are tailored to the different shifts that staff may be working. So this brings me towards the end of the talk, and I'll just outline, in case you're not aware of this CDNA COVID-19 outbreak guideline for residential care facilities, it's something that you'll need to become very familiar with. In terms of further information, there are a bunch of resources here with hyperlinks. I'll note that there is COVID-19 infection control training that's been provided by the Commonwealth Department of Health that's online. And we also have a number of fact sheets on our website, and the CDC contact details for our team are available at the bottom of the page, including business hours and after hours contacts. So I'll now hand over to Dr. Marianne Kulh, who'll talk about the GRACE service and the ACT.
Good morning, everyone. Thank you for getting up this early to come and listen to us and hear more about what you can do in your residential facilities. Some of you who are on the north side of Canberra will be aware of our GRACE service. Right now, we're servicing also 4 of the south side facilities. That's Jindalee, St Andrews, Kerry Gardens and the Pines. And we're working very rapidly with ACT Health to roll out the GRACE service across all 26 facilities, including Burrangiri Respite, with this service. So just in case you haven't met the GRACE team, the Geriatric Rapid Acute Care Evaluation Service is based at Calvary Hospital. We're different from Radar, which is a service run from Canberra Hospital, because Radar services people in their own homes, so older people in their own homes. GRACE was designed really to help older sick patients within residential facilities. Our brief at the start of the GRACE trial was to establish a residential aged care outreach service to act as liaison between residents, family and carers, identified facilities, GPs, the emergency department and ACT ambulance service to improve care delivery to acutely unwell residents. So it was timely really that this service was already running when this COVID-19 pandemic started. Our service model is that we have several arms to the service. The first is providing advice, support and education to residential aged care staff. And right now we're working on a program to try and help educate staff on the acutely unwell or deteriorating resident. And we also are happy to deliver specific items according to your needs. We also provide what I think some of you refer to as a roving team, who provide acute assessment and clinical support to acutely unwell residents. We also do a little bit of case management in that we do have recurrent referrals of the same patients or residents, so that we can try and prevent admission to hospital. And we are providing some advocacy for residents as well within the emergency department and within the hospital setting, so that any treatment that can be done in the residential facility is done rather than within a hospital setting. Referrals are taken either directly from GPs in the residential facilities or specialists when they're in the in hospitals. Referrals can also come from the nurses themselves within facilities once the patient's or resident's condition has been discussed with the GP. If the GP is uncontactable for any reason, that's another reason for us to be called directly. We have mobile numbers, one of which you can see on the screen, which will be available to you so that you can contact us directly. Our team is highly skilled in assessment of acutely unwell residents, and in fact, all the team is trained in critical care. They also have advanced nursing practice, so that some of our team members are comfortable with managing PEG tubes, urinary catheters, as well as wound management. They also experienced having difficult and complex conversations with families and residents, particularly around end of life. When we reviewed through our 2-year trial that we conducted, when we reviewed what Grace actually did within the residential facilities, these were the top interventions. So we do on-site assessment of acutely unwell residents. We've been involved in advanced care planning and palliative care, although would prefer to defer that to our palliative care colleagues based at Clare Holland House. We also do medication reviews, noting that medications can have significant impact on people presenting to hospital. Falls assessment is also frequent, respiratory assessment, non-acute follow-up after discharge, wound assessment, urinary catheter care and education. So in terms of specifically what's happening for this COVID pandemic, I've mentioned that we are prepared to do any education around recognising the deteriorating patient and other potential complications of respiratory illness. We do have nurses who can assist with training staff on collecting flock swabs. And I think that the rest has been covered by Miranda. I'll also not so much talk about testing. Oh, I think you've also covered prevention. So, and I think just with restrictions to accessing residential aged care, we are aware that a number of GPs are reluctant, understandably, to go within residential aged care facilities, and if possible, GPs advocating for teleconference style consultations. At the moment, the Grace staff are prepared to go into the facilities in situations where a patient's deteriorating. I won't go through the other things. I think notification is also being covered. So what can we do within the residential aged care facility? We can basically provide the actual assessment of the person with an acute respiratory illness. We can also, if needed, we can refer to hospital in the home so that they can provide intravenous antibiotics or subcutaneous fluids for managing dehydration. And we also cross-refer to the palliative care team so that end-of-life care can be commenced. Now, when we met last week as a senior forum, there was mention of shortage of syringe drivers and things like that. So we'd be interested to know your input as to your access to those things. One of the things we emphasise is when we are contacted that vital signs are available, including blood pressure, temperature, pulse, and oxygen saturations for that patient. We've heard that some facilities are having difficulty getting oxygen saturation monitors. So if that's the case, we'd like to know about it. We can also assist with transfer of residents to hospital when required. And this will be via the ambulance, obviously, but we can be liaison between the residential facility and the hospital to ensure that there's minimal exposure of the COVID-19 patient to other people.
Thanks very much, Marianne. Hello, everyone. My name is Dr. Vanessa Johnston. I'm a public health specialist here at Health Protection Service, ACT Health, and part of the public health leadership team that's responding to COVID-19. So we're going to take some questions now. I have a list here. I've got lots of people in the room that are going to assist me. Some of these are of a clinical nature, some of which I think you've touched on, but we might just reiterate and some infection control questions too. So the first one's quite easy. It's about sending out the PowerPoint presentations, and we can definitely do that. We'll also make this webinar available either on Capital Health Network or ACT Health, but we'll send you the link and we'll definitely send you the slides. That's straightforward. We'll also likely put together a compilation of frequently asked questions for people in the aged care sector, and we'll be in constant liaison with you about the situation as it evolves. So please rest assured that we will provide you the information that you need at the right time. I think, Marianne, you touched on this a little bit, but one of the questions is about an escalation scale for directing patients to the next level of care.
Yeah, we're at the moment developing a flow chart which will be distributed to all residential care facilities. Where a resident can be managed within the nursing home, we'd prefer that. So even if that involves providing nasal prong oxygen, subcutaneous fluids, managing fever and other symptoms, we'll manage that within the residential facility. Once a person is needing more respiratory support, such as higher flow oxygen and other interventions for infection, then they'll need to be transferred. So the assessment will be done either by the resident's general practitioner or by the Grace nurse.
Do you want to stay up there for the moment? If required, how can we access palliative care services for patients who are not yet on the books of a hospital or Clare Holland House? We have no access to comfort orders if we can't get a GP to attend.
Okay, so fortunately the palliative care team, the PEACE team, led by Johnston from Clare Holland House, now staffed to 5 nurse practitioners, and so they'll be available as previously they were, to carry out advanced care plans, to also initiate end-of-life care as needed. So it'd be through the home-based palliative care team, and it won't matter if that resident is not on their books already. So it's just a matter of contacting the team.
Possibly along the same vein, will non-ACT Health end-of-life plans be recognised by, it says ACT Health here, but I think it's Canberra Health Services.
Yeah, so definitely. So as per legislation, any advanced care plan will be recognised within our health facilities.
I'm not sure, Marianne, if you can answer this, but perhaps in your discussions with Clare Holland House, is there a pastoral care contingency for relative staff given expected number of deaths?
No, Virginia, do you want to talk about that? So Virginia Bennett, our nurse.
Hi. Yeah, look, I actually spoke to the palliative care nurse practitioners yesterday, and they've got volunteers that will go into the facilities if required.
Great, thank you.
Okay.
Sandy, this is one for you. Sandy, our infection control manager here at ACT Health. Can you go through again the protocol for cleaning a room of a person who is suspected or confirmed to have COVID-19 after use?
A terminal clean.
Well, I guess you could cover both.
Hi, I'm Sandy, the infection control manager at ACT Health. I get for the cleaning of a room when you've got a COVID-19 patient in there, it'll need cleaning, or just daily cleaning. You just need to clean all those surfaces, all the surfaces near the resident, the bedside table, the bedside table, the tray, where the table that they put there, the meal. Sorry, where their meals go on the what's that called? The tray. The tray. Yeah, and also underneath that, any surfaces they touch, light switches in the room, door handles, and use that depending what you're doing, whether you're doing your 2-step clean or your 1-step clean, and you'll probably find that a 1-step clean is more efficient for your cleaners to do. And cleaners should be wearing their full droplet PPE, which is again the surgical mask, gloves, gown and eye protection. If the patient is extremely unwell, it's probably a good idea to wear a P2 mask instead of the surgical mask. If they've been designated as being having pneumonia and acutely unwell and a lot of coughing, it would be a good idea for the cleaners also to put on a P2 mask while they're cleaning that room. A terminal clean, a terminal clean would involve cleaning of the whole room, mopping off the floors with a disinfectant detergent solution. If you've got carpet in the floors, it'd be best to have those carpets steam clean and the carpet cleaners wearing personal protective equipment.
And Sandy, you don't need to come up here again, but in terms of the terminal clean, that would happen after the resident has left that room. Like, for example, if they were being transferred to hospital. Yeah. And so you're preparing it for a new person coming in. Okay, thank you. I don't think we have any further questions. I hope that means we've answered all your questions at this stage. You may come up with more as you ponder this presentation, and that's okay as well. You can always contact us. And as I said, more information and a list of frequently asked questions we made available. I'm just going to turn to Miranda to see if there's anything further you would like to add. Marianne, yeah, sure.
I believe there's a senior managers meeting for residential care facilities on the 1st of April, and Virginia and I will be at that meeting to field any questions, as will be the Health Protection Service. So perhaps bring some of your questions to that meeting on the 1st of April. Hope I got that date right.
I think it is. Yeah.
I'll just add that we'll also be sending out a letter shortly to aged care facilities outlining a lot of the information that was presented in the presentation today, including when we want to be notified about a potential COVID-19 outbreak, the symptoms to look for in residents, and the PPE that should be worn by staff caring for a resident who is suspected to have COVID-19.
Okay, so I think, as I said, look out for our frequently asked questions. I'm going to draw this to a close. Thank you again for joining us this morning. We really appreciate your time. We appreciate everything you're doing. We are doing everything we can to protect your vulnerable residents, and we know that you are as well. Thanks very much, and good morning.